All right, we are working our way through this airway and breathing course. Only 4 more lessons left, just 2 more units. And so, you know, this one is on support tactics, insertion of gastric tubes. The other one in this unit is on ET2 suctioning. Both of these are pretty quick. There's some stuff on your Moodle to support it with, and these are good to play with in the lab to get a real good feel. So, why would you even use a gastric tube? Well, gastric distension is a big deal. It limits the excursion of the diaphragm, so your ventilation's not as good. You have kind of a ticking bomb to where that patient could let go anytime and vomit and then aspirate. And this just really doesn't take very long to do, especially if you have a king airway in place. It's almost insane not to try it and to place a gastric tube and at least relieve that pressure. And it's just one of those things that I like to do, but I'm weird, and not lots of folks are big into placing gastric tubes in the field. I think it's just a more professional way to manage that airway instead of sit and stare at my guy for a minute or minute and a half on the way to the hospital. I can drop a gastric tube pretty quick. If it goes down the mouth, it's called an OG, orogastric tube. It goes in the nose, called an NG, nasogastric tube. Either way, it's a gastric tube. You need to be able to measure them as shown. We kind of like to go to the xiphoid, maybe a xiphoid to belly button, halfway in between, somewhere like that, at least to the xiphoid. Run it up around his ear to kind of approximate going back in his posterior pharynx, and then back to the nose or the mouth. I need to be sure to cap that off. I take the, and you can see this when you hold the tube, but you take the little white adapter thing and cap it off on the end so it doesn't, the gastric content doesn't come out immediately and get all over the place. Lube up the distal piece of it, insert that tube into their nose or into their mouth, verify you're in the right spot with a syringe, and secure it with some tape, or I like to use a VenaGuard. Here's some hints and tips on those intubated patients. Hey, why not use your DL or VL scope to lift that jaw and see where you're going? Be sure you cap it up before you insert it, or you're going to end up wearing whatever was coming up through that tube. And you can verify it with a 60cc cath tip syringe, which is the weird syringe. The only time you use this on the ambulance is for NG tubes, a turkey baster looking tip to that thing, as opposed to a lure lock or slip tip for IV stuff. And you use that to inject an air bubble while you listen over the epigastrium. Now, a lot of times you place the gastric tube and you get gastric content right away, and it's fairly obvious that you're in the stomach. But what if you don't? Then that's how you would verify it. And I really like the VenaGuard, particularly the VenaGuard Junior. Works great to secure these to the nose. We'll show you how to tape them in place as well. This is a quick piece of a lab session sometime, and one of those things that, if you do it, it's in your toolbox, you ought to pull it out and use it. And it is a little bit of extra that makes a difference, I think, on airway management overall.